So what I'm going to do over the next 40 minutes is talk about a simplified approach to the brachial plexus. And again, my disclosure is I do consult with an AI company, but again, I'm not going to be discussing artificial intelligence in this talk. So I'm going to start this out by saying the brachial plexus is one of those really challenging areas. And what I hope to do by the end of this talk is that these are all different parts of the head and neck. And you can see masses here involving the right side of the neck. You see something here involving the neck. Then you see, this is a head and neck talk, but there's something involving the shoulder. So, what I hope to do by the end of my 40 minutes, and I hope to get through all the cases because I have about 10 cases. And I think, for at least for me, the way you learn the brachial plexus is really going over through cases. So my goal for this is that by the end of this talk, you'll realize that all of the abnormalities that you see here are actually attributed to the brachial plexus. And if I don't accomplish this by the end of this talk, it's not your fault. It's actually my fault. So I'm going to put the onus on myself and not you. Now, when I look at this, I'm going to start off with this painting right here. And you're going to say, why is this guy showing the painting? Well, when I look at this, the first thing that I did when I saw this painting is I saw this woman and this man looking lovingly at each other. That was the first thing that I saw. But on the other hand, when I looked in it, I actually see two musicians right here playing. I think this musician is serenading this woman, I believe. And then I want to look even closer. I see a woman under an arch. And so where I'm going with this is that when you look at something like this, your eye is trained to look at a certain part of an imaging study. So in fact, when I show this image on the right, this axial T1 weighted sequence, you're probably first looking at the trachea, you're looking at the thyroid gland, you're looking at the vertebral body, and you're looking at the cord. So when I first look at this, I'm sort of seeing the man and the woman looking lovingly at each other. But on the other hand, if you look more closely at this, the brachial plexus is actually on this study. And in fact, when we get done with this talk, you'll hopefully be able to see that this is the anterior scalene, this is the middle scalene, and between the anterior and middle scalene muscles is in the brachial plexus. So my point is that if you've ever looked at a cervical spine MRI, if you've ever looked at a neck study, if you are looking at the larynx, or if you are looking for lymph nodes, so on and so forth, the brachial plexus has always been staring at you like this musicians are, like this woman in the arch are. And my hope is that once you start looking at these, you'll always be able to identify the brachial plexus because it's been seeing you. You may not have been seeing it, but it's actually seeing you. Now, the one thing we all have in common is that we all went to medical school, and the common lexicon that we have is the anatomy. And when we looked at the anatomy of the brachial plexus, it was divided into roots, the trunks, the divisions, the cords, and the branches. Now, I always had a hard time remembering this. So what I always remember is that radiology techs drink cold beer. Now, I don't want to offend anyone. If you want to change the B to beverages, that's completely fine. But I know in the United States and the people that I work with, I know our radiology techs drink cold beer. So this is the mnemonic for me for looking at the brachial plexus. So when we look at what I refer to as the classical anatomy of the brachial plexus is formed from C5 and it goes down to T1. Now, there is a prefix and a postfix plexus, which I won't get into, but the bottom line is C5-3-1 through T1 are the main components. So C5 and C6 combine to form the trunk. So this is our radiology and these are our texts. C7 continues by itself, and then C8 and T1 combine to form the lower trunk. So we go from our radiology to our texts. Now, what do our texts like to do? Well, they like to drink. And what does the D stand for? Well, the D stands for the divisions. So we go from our roots, the trunks, to the divisions. And on this schematic illustration, we were at our trunks, and now we're going to the various divisions. Now, what the divisions end up combining to form are the radiology text, drink, and the last one is the C, the cords. And the cords of the brachial plexus are formed by their relationship with the axial artery. So there is a cord that's posterior to the axial artery, there's a cord that's lateral to the axillary artery, and then there's a cord that's medial to the axillary artery. And these three form the cords of the brachial plexus. And not only is the terminology important, but also this very, very tight relationship to the axillary artery is going to be very important when we start identifying the normal anatomy of the brachial plexus, and then when we start looking at pathologies of the cords of the brachial plexus. So what we've done so far is that we talked about the normal classical anatomy of the brachial plexus, which we all learned in medical school. Now, the surgeons have their own anatomy. So if you are working closely with head and neck surgeons or potentially neurosurgeons that sort of live in the brachial plexus, they divide the brachial plexus into a supraclavicular brachial plexus, a retroclavicular brachial plexus, and an infraclavicular brachial plexus. And obviously, this is named by the relationship of the clavicle. Now, the nice thing about this is that when you look at what is included in these three this classification of the brachial plexus, it's the classical anatomy we just talked about. The only difference is that when the surgeons operate on this, they have to know whether to stay above the clavicle, they need to take the clavicle out, or they need to go below the clavicle in the chest wall. So the supraclavicular brachial plexus are the roots and the trunk. So these are our radiology and our texts. The retroclavicular brachial plexus is formed by the division, so that was the D that we talked about. And then the infraclavicular brachial plexus is formed by the cords. Now, I haven't talked much about the branches yet. We'll get to that a little bit later. But for our intents and purposes for routine brachial plexus imaging, it's this anatomy that we have to be more concerned about because that's what's most easiest to see when we look at our imaging studies. So what we've done so far is that we talked about the the classical anatomy, the supraclavicular portion of the brachial plexus, the retro, and the infra. Now what I'm going to do is tie it all together and discuss what I refer to as the radiological anatomy. And when you look at the schematic illustration, you'll see that that part of the brachial plexus that's above the clavicle, so this is what we refer to as the supraclavicular plexus, is identified by the anterior and the middle scalene muscle. So the supraclavicular portion of the brachial plexus runs between the plane of the anterior and the middle scalene muscle. So when we look at the classical anatomy here, you're probably going from top to bottom because you can see the sternocleidomastoid muscles, you can see the thyroid gland, and then you see this vertical line. And this is what we showed earlier. There's the trachea, there's the esophagus, there's the vertebral body. But instead of looking at this cross going from top to bottom, what I want you to do is look at the horizontal portion of the cross. Because when you look at the horizontal portion of the cross, there's the anterior scalene, here's the middle scalene, and right between the anterior and the middle scalene muscles is the supraclavicular portion of the brachial plexus on this anatomic image. Now, this is from the Visible Human Project, so they did a beautiful job, identifying exactly the beautiful anatomy of the head and neck. And we can, again, see this easily on imaging. So when you're looking from top to bottom, this is the vertical part of the cross. Now look at the horizontal part of the cross. There's the anterior scalene, there's the scalenus medius and posterior, and right between them are the supraclavicular portion of the brachial plexus. So that's the supraclavicular portion of the brachial plexus. Now, when the surgeons start talking about the retro and the infraclavicular portion of the brachial plexus, we can identify this pretty easily by looking at this constant anatomic structure, and that's the subclavian artery. So when you look at the subclavian artery, as we talked about before, this gives rise to the names of the cords of the brachial plexus. So the retro and the infraclavicular portion, which are formed by the divisions and the cords of the brachial plexus, can be easily found if you can see the subclavian artery. And the reason why I take this approach is that if you do head and neck, then you're sort of used to looking for the brachial plexus. But if you do neuroradiology even, or if you do general radiology and you're trying to find the brachial plexus, sometimes you just try to find the individual components. And it's almost like looking at a needle in a haystack. The approach that I take is I look for the big structures. I look for the anterior and the middle scalene muscle. There's the brachial plexus. And then what I do is I look for the subclavian artery. And if I look for the subclavian artery, I know the cords of the brachial plexus have to be right next to the subclavian artery. So this is another example of the brachial plexus. Lots of beautiful anatomy. We see the lung apices as we just saw before. We can see the vertebral bodies. Now, the way that I look at this is I find the subclavian artery, and lo and behold, there are the cords of the brachial plexus running right along it. On the left-hand side, there's the subclavian, the axillary artery. There are the cords of the brachial plexus. So what I want to emphasize to you is look for these big structures that we all know that are there. And once you find those big structures, just like that man serenading the woman or the woman under the arch, the brachial plexus is right there for you to see because it's been staring at you full time. Now, what about the MR protocol? As I've sort of traveled in my journey and during my, various trips and experiences, what I sort of believe in is a base MR protocol because the protocols vary so much based on vendors. A lot of it is just based on preferences, where you train, so on and so forth. But what I like to consider my base protocols is I like to start off with the sagittal T2. Then I do a coronal non-contrast T1 weighted images, which to me is an incredibly important sequence. We will talk about the STIR or the fat suppressed T2 TSE sequences. Again, this terminology varies by the vendor. I always do an axial T2. I do a T1 without contrast and then a T1 with contrast. So these are my base sequences. In general, my approach is to me, the shorter the MR protocol, the better the images turn out. Because I don't know if you've been in an MR recently, but they're still pretty loud, they're still pretty narrow. And the longer you're in there, the greater likelihood you're going to move. And I like to keep my sequences short because if you have a 5-minute sequence and the patient moves at 4 minutes and 30 seconds, you've lost that whole sequence. And invariably, when you do give contrast, the contrast images are oftentimes the most important sequences, and you give contrast right at the end of the time the patient is in the scanner, and they're more apt to move. And again, those are often affected by motion artifact. So for instance, when you do give contrast here, you can see this enhancing mass that's located between the anterior and the middle scalene, but we're going to have a lot more to say about that coming up. So what is a brachial plexopathy? A brachial plexopathy is defined by supraclavicular and shoulder pain. The pain is oftentimes worsened by either palpating the area or sometimes by shoulder movement, and sometimes the pain's associated with a palpable abnormality. So the bottom line is that I think all of us in our life have had some type of pain at the base of the neck. We've all had shoulder pain. I play tennis and I play golf and I get shoulder pain lots of times. And I don't know whether it's an individual nerve or it's something wrong with my brachial plexus. So granted, sometimes these patients are imaged and we're not 100% sure whether it's actually due to a plexopathy or it's due to an individual nerve root abnormality. But the point is that in general, if you have more of a diffuse pain involving your shoulder or your arm, this is more indicative of a brachial plexopathy. Now, there are various etiologies for brachial plexopathies. They can be due to vascular causes, traumatic, tumor, or inflammatory processes. And when I go through the cases, we're going to touch on all of these potential causes of brachial plexopathy. So one of the areas that is sometimes overlooked when we evaluate the brachial plexus is the thoracic outlet syndrome. So the thoracic outlet syndrome is due to a brachial plexopathy, and it's oftentimes due to some type of abnormality involving the anterior scalene or a cervical rib. So when I was growing up, I was always taught the sagittal images were the way to look at the brachial plexus. I find actually these the most confusing. I like to rely on the axial and the coronal images, as we'll see in a couple of slides. Once I understand the axial and coronal, then I can sort of make sense of the sagittal. So in this case, this is the sagittal images. The patient's looking to your left. So this is anterior, this is posterior. And what we see here is the anterior scalene muscle. This is the subclavian artery. And these yellow arrows nicely point at the cords of the brachial plexus. And we see a nice fat plane surrounding the subclavian artery. But in this case, this patient had a brachial plexopathy, and what we see here is diffuse hypertrophy involved in the anterior scalene muscle. And look what it's doing to the subclavian artery. It's narrowing the subclavian artery and literally pinching it against the thoracic wall. So when I see this type of pinching, I know that the brachial plexus has to be involved. Why? Because the cords, the components of the brachial plexus are right adjacent to the subclavian artery. And this patient, if they do want to be treated, typically has to undergo an anterior scalene release. Another example here, this patient has right-sided thoracic outlet syndrome. They have a cervical rib. So they have a cervical rib. We all have cervical ribs, but what's the cause of the patient's pain? Well, when we look at the CT angiography, what we see here is the subclavian artery has a normal caliber proximally, a normal caliber distally, where it becomes the axillary artery. But we can see right here at the level of the cervical rib, we can see pinching of the subclavian artery. So if that subclavian artery is pinched and narrowed like this, we know the brachial plexus must be involved because it's running directly adjacent to the subclavian artery. So these are two examples of brachial plexopathies due to thoracic outlet syndrome that can be treated, but we have to make sure that we know the anatomy to make that diagnosis. So what I'm going to do now is I'm going to spend the remainder of the time showing you cases. And I think for the brachial plexus, I think that, at least for me, this is the way that I can really, this is the way I learned how to do the brachial plexus. So this is the first case that we're going to show. Now, this is a 30-year-old male that presents with an enlarging right neck mass. Now, this is a non-contrast T1 weighted image. Now, I want you to take a real close look and say, what do you think the most likely diagnosis is? Is this a lipoma? Is it a liposarcoma? Is it a hematoma? Or is it a rhabdomyosarcoma? So why don't you all go ahead and vote, and we'll see how you guys work out, and then we'll discuss this case in detail. Good, you guys are voting quickly here. I love it. I'm from Kentucky. You may have heard of the Kentucky Derby. So when I'm seeing these polls go on, it's like a horse race to see who's winning and who's losing here. So we have about 24 people. Now we're up to 27. We can get to 30. I know we can do it. Give me 2 more. Hopefully Minerva and Tim voted. All right, that got us there. Okay, so we have 50% saying hematoma, and 20% saying rhabdomyosarcoma, 13% saying liposarcoma, and 6% saying lipoma. Now, the answer here, in order to make the diagnosis, is number one, it's a 30-year-old, and it's a non-contrast T1 weighted image. So remember, rhabdomyosarcomas shouldn't have this slightly high T1 signal on non-contrast T1. And then also, notice in this case, the fat is really, really bright compared to this lesion, which is sort of intermediate, or not, it's a little bit higher T1 signal, but certainly not as bright as the fat. So this actually was a hematoma from a pseudoaneurysm. And this was a bit of an older case, but it was such a beautiful case that I still like to show it. And what we see here on the sagittal images is that this is a sagittal image, anterior and posterior. This is the subclavian artery, and what we see here is the actual swirling of the jet of flow from a defect in a subclavian artery that's forming a pseudoaneurysm. And what we see here is a pseudocapsule that's formed a pseudoaneurysm. So the point of this case is that if you do feel a mass involving the base of the neck, in the back of your mind, anything that extends to the base of the neck, especially once it starts to kiss here, the top of the lung apices, you always have to consider, is it involving the brachial plexus? It's just like looking at a sinus CT. When I look at a sinus CT and I see a polypoid mucosal mass involving a nasal cavity, the first place my eye go to is the cribriform plate to make sure I'm not looking at an encephalocele. It's the same thing with the brachial plexus. When I see something like this, where my eye goes to is I want to make sure it's not an aneurysm and it's not something that if the surgeon's biopsy, they're going to be really upset at me for not thinking about it. And this is another example. This was years ago. If you look real closely, this was a patient that had a gunshot wound. That's a little bullet right here. And this patient had multiple pseudoaneurysms involving not only the carotid artery, the brachial plexus. This ended up being coiled and the patient's brachial plexus resolved. So here's the next case. This was a newborn with right shoulder dystocia following a vaginal delivery. So what's the most likely diagnosis? Is the diagnosis congenital meningoceles? Are they traumatic pseudomeningoceles? Are they multiple cystic schwannomas or rhabdomyosarcoma? Right. We got the votes coming in. Okay, we got 15. I know we can get more. We're 21, 23. All right, excellent. I think this one, you guys pretty much got this one. I think 90% got this right. And these are traumatic pseudomeningoceles. And I show this for a specific reason. Number one is that when we do think of the brachial plexus, we always think of the brachial plexus sort of at the base of our neck. But as we discussed, when we went over the original anatomy, the brachial plexus it has the roots as a component. So remember roots, trunks, divisions, cords, and branches. So remember the roots of the nerve roots form the brachial plexus. And these are examples of pseudomeningoceles. So when you have a normal vaginal delivery, what sometimes happens is that as the baby is coming out of the vault, there's a little narrowing right there. And if the vaginal vault is too narrowed, as the OB gently pushes ahead, the shoulder gets caught. And this is what we referred to as the shoulder dystocia. And unfortunately, if there's too much pulling action, you can end up getting a stretch injury that typically involves the roots of the brachial plexus. So just a couple of things about this. This is what the normal palsy looks like. This is sometimes called the Erb's palsy, where we have shoulder dystocia and internal rotation and pronation. Now, this is the example of a pseudomeningocele. So what's felt to happen is that the nerve root gets avulsed, and therefore you have a little rent in the dura, and you have this contained collection. So this is felt to involve C5 and C6. Now, when we do a CT myelogram, and CT myelograms are still performed in newborns, normally you can see the ventral and the dorsal nerve root. Now, realize when it's a little bit debatable, but I once learned that if you have a nerve root avulsion, you will always have a pseudomeningocele. But just realize that sometimes you can have nerve root avulsions and there's no pseudomeningocele whatsoever. So the fact that if you don't have a pseudomeningocele doesn't mean that that nerve root's intact. Realize on occasions you can have avulsion of the nerve roots and have no pseudomeningocele whatsoever. So this emphasized the fact that nerve roots are a component of the brachial plexus. So this was a 45-year-old male who was unable to move his left arm following a motorcycle accident. What is the most likely diagnosis? Is it a soft tissue laceration with an intact brachial plexus, traumatic pseudomeningoceles, ulcerative neoplasm, or total plexus avulsion? And this is a stir sequence here. I got to answer my question here myself, so hold on for a second before I can see what you guys say. All right. All right. Okay. Got 12. We can do it. Do it. Keep going. We can get to 20. All right, excellent. So everyone's trending here with the correct diagnosis. And this is going to be a total brachial plexus avulsion. Now, these are pretty rare. The most times that I've seen this happen have been in accidents, actually. I haven't seen that many of them, but that's what I've seen. In this case, we could see basically the shoulder soft tissue has been completely resected, a very, very bad traumatic injury. And on the stir sequence, in this particular case, we can see abnormal increased signal involved in the brachial plexus on the left compared to the right. So this is the edema that we would expect to see. Now, this was a different patient that, again, also had a total plexus avulsion, and we did a CT myelogram. And we don't necessarily see the contrast material leaking out into all of the soft tissues. Remember, the brachial plexus is a very, very thick structure, and it's surrounded by a very thick perineural sheath. So when we do have a total plexus avulsion, if you do perform a CT myelogram, just like we saw before, this contrast material tends to be pretty well contained. So don't expect it to leak out as you would, let's say if you had like a hole in a can and everything started to leak out. It's really tough to rip this perineurium. So that's why you have this sort of contained collection of contrast material when you do have a total plexus avulsion. All right, we'll go to the next case. This is a 60-year-old male that presents with a right-sided brachial plexopathy. What's the most likely diagnosis? Is it tuberculosis, benign pleural fibrosis, a superior sulcus tumor, aka Pancoast tumor, or metastases? And again, the question is, what's the most likely diagnosis? Okay, we're getting there. Excellent. Okay, the correct answer is the superior sulcus tumor or the Pancoast tumor. So when we look at the patient that has a right-sided brachial plexopathy, and especially in an adult, when we see an aggressive mass right here involved in the lung apex, we know that there's probably something ominous going on. And this is an example of a superior sulcus tumor, Pancoast tumor, or we can call it lung cancer. It has lots of names to it. But the point is that these tumors tend to involve what we refer to as a superior sulcus. And the reason that they result in a right brachial plexopathy is that they can extend through the fat involved in normal lung apex. And if you look closely, the red arrows here point at the subclavian artery, and right above the subclavian artery are the components of the brachial plexus. So just as in this case, where we see this tumor kind of creeping up and involving the cords of the brachial plexus, this is what we see here, where you see this tumor growing up, encasing the subclavian artery, and right above it are the cords of the brachial plexus. And this is another example of a more advanced case of a superior sulcus tumor. This one actually grew all the way through the lung apex, completely encased the carotid artery. And if you look real closely, we can see some components of the brachial plexus leaving this mass. And on the T2 weighted turbospin echo sequences, we can easily see the tumor, but you can also see the resultant inflammation and edema involving the cords of the brachial plexus. So this was an example of a superior sulcus tumor. All right, here's the next case. A 30-year-old male with palpable right neck mass. What's the most likely diagnosis? Is it A, metastatic lymph node, B, branchial cleft cyst, C, Schwannoma, or D, lymphatic malformation? So this is the contrast-enhanced CT, and this is a contrast-enhanced T1 weighted image, just contrast-enhanced T1 weighted image. I'll wait a couple of seconds. Uh, Right? We're right about 20. Hey, this is not fair. I see some people changing their responses. I don't know, Jacob, you're letting these people cheat here or not? I see some the numbers are going up and down here. I'm not sure about that. All right. So the correct answer in this particular case is a schwannoma. And I think most people got it right. I'd say three-quarters got it right. So this was the case that I showed earlier. So this is a mass involving the right side of the neck. Now, when you see something like this, when I showed this initially, you probably thought, is it a sarcoma? Is it some type of fibrous tumor? Is it a branchial cleft cyst? I mean, who knows what? So one of the things that I want to emphasize is draw a line down the middle, compare the left side to the right side. And on the left side, we can see the anterior scalene, the middle scalene, and between these planes is the brachial plexus. Now on this side, you can sort of see the anterior scalene here and the middle scalene here, so it sort of looks like that plane. But when you are reading out these studies and you see a mass in this location, there was an old saying the only way you have to think of the diagnosis before you can make the diagnosis. So when I see something down here that's involving the paraspinal region and it's in relatively close proximity to the foramen, I always think to myself, is it possibly this could be arising from the brachial plexus? And this is when I would do an MR. And when you do the MR, what we see here is that you have an enhancing mass that's located between the anterior scalene and the middle scalene. And again, when you draw a line down the middle compared to the left side, there's the anterior and the middle scalene muscle. And when you see something arising in the plane of these two muscles, we know it has to be in the brachial plexus. And if it's round like this, then we have to think of a neurogenic tumor. And the only option in this case that I gave you was schwannoma. So remember, schwannomas arise from the Schwann cells. They now don't arise from the neurofibrils, but the Schwann cells. So essentially, they are eccentric, as we see here. It can sort of splay the various nerves. And the surgeons can go in and literally just pluck this out. And this just is an example of a stir sequence a little bit more elegantly demonstrating the schwannoma that's arising from these nerve roots. Now, I will show more stir images and more advanced techniques later, but for me, the most important thing in my approach basically to head and neck is that you've got to learn the anatomy. You know, I think the purpose of advanced technology is to better understand the anatomy. Sometimes I think people, especially as more options come in, we get too caught up in the technology. But remember, the purpose of advanced imaging and technology, at least for me, is to really better understand the anatomy. So to me, the anatomy is the foundation of everything. So here's another patient. This is a patient with a 30-year-old male with skin lesions, presents with a left-sided brachial plexopathy. What is the most likely diagnosis? Is it a leiomyosarcoma? Is it schwannomas? Is it neurofibromas? Or is it metastatic lymph nodes? Give it a few more minutes here. Good. Perfect. I think everyone, this is great. I think everyone got this one right. So either the questions are too easy or I'm teaching well. We'll let the audience figure that one out. Actually, it was 86% got it right. So the example, the correct diagnosis are neurofibromas. So in this case, again, you see a mass right here and you're trying to figure out what is this? Key thing is to give contrast. Now, when you give contrast, again, notice the locations between the anterior and the middle scalene muscle, and then we see these cannonballs and enhancement between these two muscles. So again, when we see these lesions involving the anterior and the middle scalene muscle, we know that it's involving the brachial plexus. And when we see multiple lesions like this arising between these two planes, and in this case, it was a younger patient with multiple skin lesions, then we can make the diagnosis of neurofibromas. Remember, neurofibromas actually arise from the nerve fibrils, so they cannot be plucked out, if you will, as a schwannoma. Now, occasionally some surgeons will go in and try to resect this, but in general, that's not routinely done. And this was the case that I showed earlier. When you first looked at this, you may have thought, hey, Is it possible this could be multiple lymph nodes? But when you look real closely, there's the anterior scaling, anterior scaling, middle scaling, and these multiple lesions are arising between these two planes. So again, when I'm looking at CTs and MRs and I see multiple enhancing lesions, I always want to make sure that these lesions do not extend between the anterior and the middle scaling muscles, because if they do, then I completely change my diagnosis and I start thinking about neurogenic lesions. Well, this is a 55-year-old male with NF1 previously treated for a right brachial plexus neurofibroma, now presents with an enlarging neck mass. What's the most likely diagnosis? Perfect. And I think people got this one correct. Now, patients with NF1 that have very large neurofibromas that are symptomatic are still occasionally treated with radiation therapy. So in this case, what we have is a very, very large aggressive mass involving the right neck. Notice how it's following the right subclavian artery. So given this oblique orientation right here, this is more suggestive of something that's involving the brachial plexus. Again, notice that relationship to the subclavian artery, and notice how this corresponds very nicely with the brachial plexus. So about 10% of patients with neurofibromatosis type 1 will go on to develop a malignant peripheral nerve sheath tumor. We cannot differentiate a malignant peripheral nerve sheath tumor from a neurofibroma on a single study. You just can't do it. But if the patient has an enlarging mass and it's an interval enhancement, then that is suggestive of a malignant peripheral nerve sheath tumor. So, and just remember, it is a delayed complication of neurofibromatosis type 1. Now, this was a patient, and I've got about 2 minutes left. So what I'm going to do is I'm just going to go through the last few cases because I think it does make a couple of points. This was a patient with a Pancoast tumor that was treated with about 6,000 grays and also had chemotherapy, and presents 4 years later with a brachial plexopathy. And what we see here is this mass involving the right-sided brachial plexus. The question here was, what's the most likely diagnosis? And in this case, it was radiation-associated brachial plexopathy. And the point that I want to make here is that when I see a patient like this that's post-treatment, yes, I can see the abnormality. And in general, in my experience, if someone took a brachial plexus and glued it together, like they took Elmer's glue or some type of glue and glued everything together, that's more indicative of a radiation-associated brachial plexopathy. But what's more important to me is to get more history and figure out what the dose was and the number of years after completion of therapy. Because if the patient had higher dose, and the patient, this occurred 4 years later, then this is more associated with radiation-associated brachial plexopathy. This was a case I saw about 5 months ago. This patient did not have a palpable mass, just had a brachial plexopathy. It turns out this patient was only treated with 3,000 gray, never came back. Clinically, they could not feel anything, and the referring physician thought it was a brachial plexopathy. But in this case, this turned out to be recurrent tumor. So yes, another example here, this is metastases. So again, the things that I look for is I look for the abnormalities that I see here, but I always try to figure out exactly what the dose was. So if it was a lower dose and the patient did not have chemotherapy, again, this was going to push me that this patient had metastases. This was a patient that had left-sided shoulder pain. This patient presented with a left-sided brachial plexopathy, and what we see here is diffuse sausage-shaped enlargement of the left brachial plexus. So in this case, this is not plexiform neurofibroma, but this diffuse enlargement in high T2 and high stir signal is more consistent with an idiopathic neuropathy. In this case, it was CIDP. And these type of cases where it's essentially that you perform some type of stir sequence or some type of fat-suppressed T2 weighted sequences. Because I can tell you, if you don't do these sequences, then you're potentially going to miss this. And there are various ways to do this. We don't really have time to get into the specific sequences, but that's why I always include this as part of my armamentarium. And I'm going to end on this case. This is the classic case of a 16-year-old female that was sorry about that, a 16-year-old female that was a violinist. And I walked in on Friday morning, and they said the patient has a left-sided brachial plexopathy. This patient's a concert violinist. And when I looked at this, what I saw here was the brachial plexus looked relatively normal. But when I looked at the stir sequences, notice the asymmetrical increased signal involving the cords of the brachial plexus. So I said to myself, there's something strange going on here. And then when I looked at this, I saw all of these enlarged lymph nodes here. So in this particular case, the orthopedic surgeon felt that this was brachial neuritis from overuse, but given the enlarged lymph nodes and the fact that this study was done about 3 years ago, you remember where we were then, we had to obtain more history. And it turns out this patient had recently had a COVID vaccine. And the next brachial plexus study I had was her sister. So they both had COVID vaccines, they both had enlarged lymph nodes, and they both had asymmetrical signal involving the stir sequence. And finally, just to emphasize this fact, this was a patient that had melanoma. We knew that this was metastases because this was biopsied. But when we looked at the PET CT, we saw all of these enlarged lymph nodes, and the patient had a left-sided brachial plexopathy. Now, was this actually metastases or was it something else? Well, one thing that we learned during the era of COVID, and we still should do it now, is that when I see a patient that has a brachial plexopathy and I see enlarged lymph nodes, I always ask the patient if they've ever had a vaccine in their left arm. Because as we know, vaccines are very safe. I'm a huge vaccine fan, but occasionally you can get a rare neuritis or enlarged lymph nodes that can result in inflammation of the brachial plexus. And this one last case, this was just a case of Parsonage-Turner syndrome. I don't have time to get into that one. Bottom line is here is that Parsonage-Turner syndrome is abnormal inflammation of the branches. It can result in weakness of the shoulder girdle. This is the superior spinatus, inferior spinatus. So if you do have patients that present with some type of shoulder weakness, you always have to realize it could be due to the distal branches, and then we always want to look at the nerve roots to see if there's any edema. So this was an example of Parsonage-Turner syndrome, and just realize some of the muscular abnormalities that we can see involved in the shoulder girdle can be due to the brachial plexopathy. So in summary, what I wanted to do was always remember when you see these two people looking at each other, you want to see them, but always remember to see the musicians and the woman under the arch. Because yes, in the next 20 of the cervical spines and next you look at, yes, look at the trachea, the esophagus, and the vertebral body. But in the next 20, if you try to find the anterior middle scalene and you try to find the subclavian artery, you'll always see the brachial plexus. And I can assure you that's something you'll always remember for the rest of your life. So thank you very much for your attention. And I think we're going to go to Q&A now.